Hello, and thank you for joining us for our presentation entitled Trauma During Gestation, Birth, and Postpartum, the Effect of Maternal Mental Health and Well-Being of the Mother-Baby Dyad. We are thrilled to have such a fantastic speaker today sharing insight on a very important topic. This presentation is being hosted by the Perinatal Mood Disorders Initiative via a grant funded from the New Jersey Department of Health. I am Irina Polanco Ventura, Director of Public Health Initiatives at the Partnership for Maternal and Child's Health of Northern New Jersey. The partnership is a nonprofit agency licensed by the New Jersey Department of Health, which exists to meet the healthcare needs of women, infants, and children in Northern New Jersey, while coordinating education, outreach, and advocacy through regional planning and collaboration. So before we get started, I'd like to review some important information. An hour after the webinar ends, you will receive an email with a link to a post-program evaluation. Please go ahead and complete that survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will then be sent to the email you provided within a week of the webinar broadcast. This program is being recorded and will be available on the partnership's YouTube channel, just in case you'd like to share with your colleagues. We will also be muting all attendees' microphones during the presentation, but we would love to hear from you. So I encourage you to write your questions while the speaker is presenting. You can do that at any time in the question box, and she will respond to as many as possible at the conclusion of the presentation. So now I'd like to introduce today's speaker. We are very pleased to introduce Carolyn Flynn from the Institute of the Center for Great Expectations, located in Somerset, New Jersey. The Center for Great Expectations provides trauma and informed care. This includes residential Mommy and Me programs for adult and adolescent women, community mental health services, in-home programs, and supportive housing. Their early relational health model specifically addresses attachment between mothers and their children, helping to break the cycle of intergenerational trauma, substance use, and homelessness. Carolyn is the director of the center's in-home program, START, and an early relational health clinician. She earned her master's in counseling from Kean University and is a licensed associate counselor in New Jersey. Her passion for working with pregnant persons began as a certified doula, providing education and support during pregnancy and childbirth since 2006. Carolyn is a strong advocate for changing childbirth practices to become more equitable, family-centered, and trauma-attuned. As a senior trainer at the Institute, she has presented both locally and internationally on topics including early relational health, traumatic childbirth, and intergenerational trauma. Carolyn is rostered in Child-Parent Psychotherapy and currently a fellow in the UMASS Infant-Parent Mental Health Postgraduate Certificate Program. Carolyn is a mother to 3 spirited children and enjoys writing, drumming, and camping. So thank you so much, Carolyn, for being with us today to speak about such an important issue, and the platform is all yours.
Thank you, Irina. I'm delighted to be here and so grateful for this invitation and the opportunity to share this information. Before we get started, I want to note that I have no financial disclosures to make, and if everyone can just take a moment to read through these 2 important notes before we get started. Our objectives for today. We will explore intergenerational transmission of trauma, including the mother's early adverse experiences and the experience of the prenate during gestation. We will take a look at traumatic childbirth in today's modern medicalized system and look at how the childbirth experiences impacts maternal mental health and therefore parent-child relationships. Lastly, we will talk about the crucial nature of the parent-child relationship as the basis for psychosocial well-being throughout the lifespan. We're going to get started with an overview of the ACEs study. This may be a review for some, but always a good place to start. The ACEs study put evidence and numbers behind what many of us had known for a long time, that what happens to us when we are children affects us on many domains throughout the lifespan. So the ACEs study looked specifically at 10 different adverse experiences in 3 categories: abuse, neglect, and household dysfunction. The study was done back in 1995, in between 95 and 97 by the CDC and Kaiser Permanente, with 17,000 participants who were mainly fairly well-resourced families in the Midwest, and looked at physical, emotional, and sexual abuse, emotional and physical neglect, as well as experiences such as a parent having a mental illness, witnessing your mother being treated vilely, and other situations that were adverse within the household. The study found that overall, 1 out of 6 adults had 4 or more of these adverse experiences, and that the more ACEs an individual had experienced, the higher the risk for health outcomes. So this study put some really nice numbers to a correlation between more adverse experiences in childhood and adult outcomes, such as smoking, alcohol use, drug use, and then physical and mental health issues such as depression, suicide attempts, STIs, heart disease, etc. Now, I mentioned that there were 10 ACEs that were examined in the original study. And as we took this information and were learning from this information and applying it, it's important to note that these are 10 important experiences, but they are not the only adverse experiences. And so we are now looking at what we call expanded ACEs. These are ACEs that are related to the community environment, such as bullying, poverty, experiencing racism, having multiple and traumatic losses within one's life, experiencing food scarcity, community violence, etc. And in 2012, a second ACEs study was completed in Philadelphia that took a look at the differences between ACEs in an under-resourced and urban environment. As I mentioned earlier, the original study was really done mainly on well-resourced, white, educated individuals, and so looking at this within a broader scope. And what we found was that there were a higher number of ACEs in the urban community, and that there were correlations between these expanded ACEs and outcomes. So when we compare the two studies, in the original CDC study, almost 2/3 of study participants had at least one ACE, and more than 1 out of 5 people, about more than 20% of people, reported 3 or more. However, in the urban study, 40% of individuals had 4 or more of these ACEs. So just a greater number within that urban community, and showing that these expanded ACEs did indeed have an impact. And so I'm bringing up the ACEs studies just to give a general overview that we have evidence to support the fact that what happens to an individual in their childhood before age 18 has an effect across multiple domains during that individual's lifespan, so during their own adulthood. What we're going to talk about today is about how those ACEs, how a mother's ACEs actually impact her child, how they impact the next generation. So what we have learned in follow-up studies is that babies of mothers or children of mothers who have experienced multiple ACEs have increased risk for poor physical, behavioral, and cognitive outcomes. So these impacts of ACEs are not only within an individual's lifetime, but actually have implications for the next generation. So mothers with higher number of ACEs, we see poorer infant emotional regulation at 6 months of age. And we see alterations in the infant's levels of baseline cortisol, as well as the reactivity of cortisol, so a spike upon stimulus as early as 1 month of age. So thinking about how does this happen, there's 2 main theories of transmission that we will talk about today. The first theory has been that ACEs are passed via maternal behavior. For example, a study showed that mothers who had witnessed domestic violence in their own childhood had a poorer quality of attachment to the fetus during pregnancy, even if they did not experience domestic violence while they were pregnant. So even if the gestating child was not in an environment where their mother was experiencing domestic violence as an adult, she had only experienced it between her own caregivers as a child, it affected her attachment during pregnancy. And we also see increased maternal heart rate in response to infant cry for mothers who have experienced ACEs during childhood and are not necessarily in an adverse environment as an adult. And that's important because increased maternal heart rate is correlated with maternal sensitivity. And the second theory is that changes that early adverse experiences change the mother's stress response system. So in order for her to adapt to that high stress environment, her own stress response system becomes more reactive, and that this changed response system affects the brain development of the developing fetus during gestation. So we're going to dig into that second point first. How is it that mom's own stress response would change the development of her child and her child's ability to regulate at 1 and 6 months? So we will talk about a system within the mother called the HPA axis. This is the hypothalamic pituitary adrenal axis. As you can see in the little diagram here, this is the system that controls the fight, flight, freeze response. It's a communication system between the hypothalamus in the brain, the pituitary gland, and the adrenals. And ACEs during early childhood are theorized to create a more sensitive and reactive HPA system. This is adaptive for the mother in that she's going to learn, I need to be more vigilant. I need to be able to fight or flee more quickly. So this system becomes more sensitive in order to ensure her survival. This is regulating her body's stress response, and it's increasing that reactivity. And the early childhood ACEs are causing the HPA axis to increase its production of cortisol, which is a stress hormone that activates that fight, flight, and freeze system. And when we look at what cortisol does during pregnancy, so we have a mom whose body is creating increased levels of cortisol, and this is done in order to ensure her own survival, her own ability to react quickly. During gestation, the placenta secretes CRH, corticotropin releasing hormone. This actually stimulates the mother's HPA axis, that system to secrete even more cortisol. The theory here is that this makes sense so that when the mother is pregnant, she is more vigilant. She is a little bit more capable of fight, flight, freeze quicker, perhaps because, to protect the infant, perhaps because she may have a slower response and able to flee the situation. She needs to be a little bit more tuned in and able to respond quickly. And so this is a normal thing that during gestation, the placenta is going to activate the secretion of more cortisol to protect the mom and the baby. Normally, during a pregnancy, the exposure that the infant's or the fetus's exposure to cortisol is regulated by a placental enzyme called 11-beta-HSD2. And what this does is it oxidizes cortisol to its inactive form, cortisone. So the placenta creates more cortisol in mom, but it also creates an enzyme which protects the infant from interacting with that cortisol, that stress hormone. However, adverse intrauterine conditions are associated with a downregulation of that protective enzyme. And so the infant is directly exposed to that cortisol instead of cortisone. And what we know is that abnormal levels of exposure to cortisol can create neurotoxicity and reduced fetal brain growth. Fetal programming theory talks about systems which are under rapid development being particularly vulnerable to stress and exposure to cortisol. So what we see in this diagram are the period of gestation. So we have weeks 1 and 2, the period of the ovum, and then weeks 3 through 38, and which systems, are in rapid development. What we see here is that the central nervous system, which involves the infant's own HPA axis, and the brain, which is being developed, is under rapid development, particularly from week 3 to week 20. And so throughout much of the gestation, all of these systems would be greatly impacted by that exposure to cortisol. We also have an understanding of the infant's, the prenate's own experience of the environment via the mother. There was a study done back in 2010 which looked at the prenate's response to maternal emotions. So mom was given headphones so that the infant would not be able to hear through the environment, and mom was watching two different movie clips. The first was intended to induce feelings of joy. This was a clip from The Sound of Music. The second clip was from a movie called The Champ, in which a child is witnessing their dog dying, intended to elicit feelings of sadness in the mom. So mom puts on headphones, infant cannot hear the movie themselves through the environment, and they looked at fetal arm and leg movements via ultrasound. When mom watched the happy film, we saw an increase. So if you look at the left side of your slide, an increase in arm and leg movement, and then a return to just a smidge below baseline, basically a return to the previous level of activity from before the movie clip. When mom watched the Champ to induce feelings of sadness, we see a decrease of limb movement, and then the movement did not return to baseline during the time of the study. So indicating here that the infant had a response to both the feelings of joy and to the feelings of sadness experienced by mom. So how does trauma affect the prenate's brain development? We're going to talk a little bit about the amygdala, which is part of the brain, and its primary function is to process fear and to activate the fight, flight, and freeze response. The eyes, the ears, the senses are monitoring the environment. If a threat is detected, it is sort of screened by the right part of the amygdala. And that is what, will activate the HPA axis to secrete cortisol and to either fight, flight, or freeze. One standard deviation in maternal cortisol during early gestation is linked to a 6.4 increase in the right side of the amygdala in girls. So we see that when mom is experiencing stress, the prenate is developing a larger amygdala on the right side. The right side of the amygdala is focused on the reaction to particularly emotional stimuli. The left side of the amygdala is, to very much simplify, is associated with evaluating stimuli. So we see that the infant's brain is developing to be more reactive when mom is experiencing a lot of stress. The mother's exposure to early maltreatment, so in her own childhood, is also linked to a smaller cerebral cortex in the infant. So whether male or female, a smaller cerebral cortex. And so what we're seeing here is that the fetus's development is designed to adapt to the physical state and health of the mother, that there is a system by which the prenate is receiving information about what kind of world am I being brought into, and what kind of brain do I need to have in order to survive? Can my brain prioritize the development of a cerebral cortex, which focuses on logic and planning, executive function, creativity, or do I need to develop myself a brain which is going to be reactive and keeping me able to survive in a high stress environment? So thinking about relationship between mom and baby beginning during gestation, we can see from that 2010 movie study that the infant has an awareness of the emotional state of the mother. And so we can see the mother's body, the mother's environment, as the child's environment. And studies are showing that chronic stress in pregnancy is related to pregnancy and delivery complications, increased rate of C-section, preterm birth, and low birth weight. So it's not only about the experience of stress, but also some outcomes that put the infant at risk for developmental issues throughout the lifetime. And that family dysfunction during pregnancy is associated with baseline cortisol reactivity at 2 days of age. So if during gestation there is dysfunction in the family, infants are going to have a cortisol spike to a stressful experience at 2 days of age that is more reactive than those without that family dysfunction. We see an increased risk of infants going on to develop behavioral and emotional disorders, and looking at how during the 3rd trimester of pregnancy, babies who are born of mothers with a history of childhood abuse have lower resting heart rate variability, which is associated with a decreased parasympathetic activity. So we're seeing that these babies they have a harder time with coping with these with emotional stress. So we're going to shift slightly here, move from gestation, and start to talk about the birth experience. So I have here an image of Robin Lim, who was the CNN Hero of the Year in 2011 for her work during the tsunami in Indonesia. And she has a beautiful quote that I love, which says, "Peace on earth begins with birth." And a lot of Robin's work talks about how the way that birth happens shapes mothers and shapes babies and shapes our planet. The way that we are doing birth, not everywhere, of course, there's great variation between providers and between hospitals and between birthing environments, but in general, in our country, birth is seen as a pathological process in need of medical monitoring and treatment, rather than as a normal physiologic process. This is spurred in many cases by economics and fear of malpractice. What we end up is a high-tech and low-touch birth experience. This is part of a patriarchal view that devalues intuition and wisdom and a mother's knowing of what needs to be done in her body, and an overvaluing of credentialed experts who are relying on technology and data-driven ways of knowing. So we have Robbie Davis Floyd and Carolyn Sargent talked about this as being authoritative knowledge, meaning what kinds of knowledge do we value and what kind of knowledge do we use to make decisions? Is it bodily sensations and what a mother is feeling during birth, or is it what we are reading on a fetal heart monitoring script? And really thinking about, do we need to polarize those two into being kind of a one or the other? How can we sort of integrate what we know from education and knowledge and training, as well as a mother's bodily experience? So the picture that I've put here is of a giraffe that was born in a zoo, and it reminds me of how when a baby is born in a zoo environment, we go through all sorts of things to make sure that those two are not disturbed during the birth experience. We don't want the scent of humans nearby. We keep things dark. We allow them to do their own thing. However, we expect this physiological process to unfold easily when we remove mothers from their environment and put them into a place that is unfamiliar. It's often associated with being sick, with strangers around, putting on a gown. So what does that do to the birthing experience? I'm reminded also of a story of a birth that was happening at home. There was an experienced midwife there with her apprentice, and mom was on her hands and knees beginning to push. The apprentice midwife was behind the mother, and the experienced midwife was at the mother's head. The apprentice saw that there was a shoulder dystocia, which is when the head emerges, but not the shoulder, which is a true obstetric emergency, a true birthing emergency. And the apprentice midwife went to signal to her mentor that help was, please just, move over and come near me to help. But before she could even say that, mom got out of the hands and knees position. She squatted and she kind of like chicken legged her leg out. She just did this like funky hip movement, and the baby bloop, plopped right into the midwife's hands. So without being told, you need to move into this position, or there is an emergency, her body knew. And so we need to think about, how does the birthing environment and how does the way that we do birth inhibit this wisdom that is inherent in the mom's body? There's a term called obstetric violence, which was adopted in Venezuela, and it talks about pathologizing natural processes during childbirth, dehumanized treatment during the birthing process, when families feel a loss of autonomy and an ability to decide freely with adequate information, when the mother-baby system is treated as separate. So most often, what is good for mom is also good for baby, but in this industrialized birthing system, we tend to separate the two and look at, oh, well, if mom wants to walk or move or eat during labor, that these things, can put the baby in harm, that the mom's body is actually a dangerous place and her decisions could put the baby in danger. And these are things that negatively impact the quality of life and of the dyad. And so this is not a term that is used frequently here in the United States, but I think it's important to really identify when this is happening, and certainly not to say that all providers are engaging in obstetric violence. I have the privilege of working with many, many compassionate nurses and OBGYNs who do not see this way, but our system does tend to lead to instances of obstetric violence, and we need to use that terminology. So some examples: the absence of informed consent and refusal, and without the ability to refuse, if a family does not feel that they can refuse an intervention, then we don't actually have informed consent. Those two need to coexist. Withholding or misusing information, sexualizing procedures, so talking about the husband stitch or making remarks during the birthing process that sexualize the situation. Using the body for teaching. So in my work as a doula, I have seen in particularly low-income moms who have substance use disorders, moms without insurance tend to be those that have had situations where residents are coming in and several different persons in training are learning to do a vaginal exam on mom, where 3 or 4 different people are putting their hands inside the woman's body and so that they can learn. Medically unnecessary procedures, restraint of the woman for physician convenience. So thinking about, the lithotomy position, laying on one's back, is often the least effective position for pushing out a baby. However, it does provide the most convenience for the mother. refusing medical care, using disrespectful language, or blanket policies that restrict forms of care. So not individualizing them to each situation, but just having blanket policies. And the birth experience has an impact on perinatal mental health. We like to say that the #1 complication of childbirth are emotional complications. Suicide is actually the leading cause of maternal death. And while less than 10% of individuals report alcohol use during pregnancy, about 50% report use during postpartum. We see rates of postpartum mood and anxiety disorders, 17.1% for postpartum anxiety. 9% of birthing people are meeting full criteria for postpartum PTSD, and 18% are symptomatic but don't meet the full criteria. We have 0.5% experiencing postpartum psychosis, and the numbers are much higher for Black birthing people. So 38% of Black birthing people reporting postpartum depression compared to 13% to 19% of the overall population. It's important to note too that perinatal depression is not limited to moms, but 1 in 10 dads in the US also report perinatal depression, and these are the highest rates. This in fathers tends to come out as irritability, anger, substance use, aggression, and distancing from the mom and baby. I want to talk a little bit about intrusive thoughts during postpartum. Intrusive thoughts are very common and very distressing to moms. So it's really important to have an understanding of them if families are going to come to us and be able to share that they're having intrusive thoughts, that we're able to respond appropriately. I really like to frame intrusive thoughts as an adaptive system in which the mom's alarm system is really turned up and tuned up. So, when if mom is saying, I keep having images of myself dropping the baby, or I'm afraid that I'm going to hurt the baby, or I'm afraid that I'm going to do something to harm him, or, I think I might do something to hurt my baby. That this is her alarm system being so high tuned that it's even picking up on the possibility of her doing that. It tends to be, dads have intrusive thoughts as well, but they tend to be less distressing or disruptive to the parent-child relationships for dads. It has a much heavier impact for moms. And so here, that normalizing can be really, really helpful. This is really common, and it is really distressing. So let's have a little talk more about what's going on. It's important to note the difference between ego-dystonic thoughts and ego-systonic thoughts. Ego-dystonic thoughts are ones where I'm having this thought about harming my baby. I had a thought about drowning my baby in the bathtub, and I'm horrified, and I don't know what to do. I'm so afraid that I might do it. There is not a correlation between that kind of thought and aggression toward the infant. There is a correlation between what we call ego-systonic, which is where, I really feel like my baby would just be better off without me. I feel like, my infant is maybe possessed, or my infant is evil, and the world would be better off without the baby. So there's not that feeling of guilt or shame or fear that comes along with the thoughts. Taking a look at risk factors for postpartum PTSD. This is what happens when a birthing person either actually was or believes that they or their baby was in danger of injury or death, and they felt helpless, out of control, or alone. So race is a risk factor, with Black birthing people being 2 times more likely to experience a near miss during the birthing process and to report sometimes, usually, or always being subjected to poor treatment, as compared to 8% of white birthing people. Having a history of trauma, having obstetric violence occur during the birthing experience, or when there is just disrespect that may even be unintentional during the birthing experience, feeling not included in the decision-making process. If there's jargon that's being used in the room, kind of a talking over mom, and she feels like she is not a part of things, that she's not the center, that she doesn't know what's going on, that can lead to postpartum PTSD. This is a survey that was developed by myself along with Dr. Emily Bosk at the Rutgers School of Social Work. And this is a screening tool which helps us to look at the experiences that can happen during the birthing process, which are correlated with postpartum PTSD. So this just goes through some of those situations and asks mom to rate. This is available. I can send this out if people are interested in using this within their own program. I need to note this is not a validated study. This is just a screening technique for therapeutic use to help us understand a bit more about what occurred during the birth experience that could lead to PTSD. Taking a look at the immediate postpartum experience and how important it is to have some undisturbed time for connection to develop between mom and baby immediately after birth. So I say immediately with a caveat that as mom and baby are ready. So obviously emergencies with the baby, really life-threatening situations for baby. Obviously, we would need to attend to those, as well as for mom, as well as the emotional readiness for mom. Not every mother is ready to have her baby on her skin immediately following the birth. So we always need to tune into mom and read what she's ready for. So in the first hour, if we leave mom and baby completely undisturbed, the baby placed on mom's abdomen will crawl to mom's breast completely on their own. There is a beautiful DVD called The Magical Hour, which goes through, there's 9 different phases in which the infant inches, crawls, turns their way all the way up to mom's abdomen, touches mom's breast, touches their mouth, which is the ability to focus on an object and touch it, is something that normally does not develop until 3 to 6 months of development. So that is extraordinary, and thinking about the brain connections that develop because of that. The undisturbed time for mom and baby is so important to the development of the relationship and to the infant's brain. Nils Bergman talks about the importance of undisturbed skin-to-skin contact for the first 6 hours or through the first sleep cycle of the baby. We often need to fight just for an hour for mom and baby, but he is really saying we want to have that full sleep cycle in order for that process to unfold. But overall, the first 24 hours are the most critical for wiring the mother for her caretaking behaviors. We often say that mom is nursing the baby, but Nils Bergman says the baby is nursing mom. So when the baby is on mom's skin, nursing from the breast, that is creating neural connections in mom that are associated with caretaking behaviors. We also see that breast milk from mom promotes myelin production in the baby. This is a coating on neuron which provides protection from later trauma. And I do need to make the statement here, these first hours are optimal to the extent with which we can change our practices to make this the norm. This is incredibly important. However, oftentimes it's not able to happen, and we can recreate these experiences. So it's not as if not having skin-to-skin contact early on, not having a full 6 hours means that the mom-baby relationship is doomed by any means. But this is an optimal window of time to really create these connections. And what comes from parent-child connection is the foundation for well-being. So I have two different metaphors that I like to use for attachment. And attachment being really just one aspect of a caregiver relationship. Attachment is really around the parent being a safe space for the infant, but there are many, many aspects, including and yet beyond attachment, which are important that we'll talk about later. But that attachment and the early caregiving relationship provides the blueprint for how the infant comes to understand themselves, how they come to understand other people, are relationships safe, Will people meet my needs? And the world. Is the world a safe place? If the way that mom responds to me, I cry, she responds, this is going along with the way that I am wired and the world makes sense. The attachment relationship, particularly the aspect of rupture and repair, which we'll talk about later, creates resilience in the infant. So the blueprint for who we are in the world and how I expect others to relate to me, as well as my ability to overcome adversity, is based within the earliest caregiver relationship. Infants are not born with the ability to modulate their own emotions. This develops over time within the context of an attuned and responsive caregiving relationship. We can see that very, very early on with, if we have a regulated caregiver and the mom can put the baby on their skin, their regulated heart rate will sync with the infant's heart rate. Regulated brain waves will sync with the infant's brain waves. Mom's breathing will bring the infant's breathing down. She can rock, she can soothe, she can sing. The infant learns how to regulate their own emotions on the mom's body or the dad's body, any caregiver. We also see as the infant grows that the caregiver's ability to remain grounded and regulate and to stay with the child in their own state of dysregulation is what helps the infant's brain. The ability to modulate happens within the cerebral cortex, which is underdeveloped in infants. In the right side of the cerebral cortex, this develops over time by the caregiver co-regulating with them. When caregivers either cause the distress or they are not able to modulate the child's emotions to co-regulate with them, children become unable to organize their experiences in a coherent fashion. So we talked about that blueprint. When the world doesn't make sense, when the person who is, I am wired that I will be protected, but when my protector actually causes me harm, or when I am not soothed, we create an incoherent map of the world, an incoherent map of who we are, and we call that disorganized attachment, an inability to regulate emotions. We often see later in life involvement in the justice system, homicidal behaviors, suicidal behaviors, etc. And postpartum mood and anxiety disorders adversely affect the parent's ability to co-regulate with their child, their cognitions and their beliefs about themselves as a parent, about who their child is. We can kind of get distorted perceptions of, why is my baby crying? Does that mean that she thinks I'm a bad mom? Is my baby crying because she thinks I'm an inadequate parent? Postpartum mood and anxiety disorders can kind of shift that perception. And that affects the attunement, the ability to look at the child and understand the need, as well as the ability to respond effectively and therefore create a secure attachment. So how do we as providers respond with the knowing that what happens to mom early on affects the way her baby's brain develops? That the infant is aware of what happens during gestation and has a response in the way that their brain develops. That the birthing experience affects both mom and baby. That postpartum mood and anxiety disorders, the way that mom has experienced relationships growing up, that all of this affects the infant's mental health. The first shift I would suggest is moving from parent education to building capacity for connection. So this is not a cognitive issue. If mom is responding, if her own ability to regulate is underdeveloped, if she's very reactive, if she's in cortisol, if she is in a state of not being able to attune, this is not a cognitive issue. This is not about knowing how. This is about mom being able to learn to regulate her own emotions, shifting the way she sees herself, the way she sees her infant, and building the capacity for connection. If mothers are experiencing early adverse experiences, we know that the ones that have the most profound impact are the ones that happen within relationships. So remember, there wasn't necessarily house fire or car accident. on those adverse childhood experiences. It was abuse, neglect, parent with a mental health issue. It's about having relational patterns that were traumatic. So our moms are going to build the capacity to connect with their babies by experiencing a different relationship with us as their providers. I like to say, not my quote actually, I like to repeat, everyone wants to hold the baby. Who wants to hold the mother? Thinking about that postpartum period, who is there for mom to create that space where she has the emotional capacity to be attuned and responsive to her infant? We also need to shift from patriarchal and racist views of the parent and child, not as a system, but as separate from each other. So we need to stop seeing moms and babies as separate and treating them separately, both in the birthing room and in our interventions. We need to start looking at mom and baby as a system. Some ways that we can intervene. Looking at a parallel process. And so for all of us embedded within our organizations, the mission and philosophy of the organization, the overarching goals of the organization affect the leaders of the organization. The leaders of the organization, the way that they relate to their frontline staff is going to become a parallel to the way that those frontline staff treat the families that we serve. It's a parent-child relationship straight down. So for those of us who are direct care providers on this call, the way that we relate to our families, to our moms, is going to, in many cases where individuals have experienced adverse childhood experiences or where they have had their own insecure attachment to their caregivers, they may have for the first time in their life the experience of positive attachment with us. And the way that we treat our moms creates the space for the way that they will relate to their babies. We as providers can create what Donald Winnicott called the holding environment, which then allows our moms the experience of being held, and they can then create a holding environment for their children. The holding environment is one where, as the provider, I can allow and I can tolerate any emotion that emerges from my family, from my mom. If mom is feeling rage, if she is feeling guilty, if she is feeling shame, I can just be with her in that. I don't need to fix it. I don't need to change it. I will sit with her and be with her while she feels that emotion. That creates the capacity in mom when her own child is having what we call a temper tantrum or a meltdown. When that child is dysregulated, mom will then have the ability to just be with the child in those strong emotions. We can elicit moments of joy. So when there are parents and children who are struggling, if there are postpartum mood and anxiety disorders or a traumatic experience, finding a moment of joy between mom and baby and drawing it out and focusing on it and what created that and what was that like for you, and really bringing that forward. We need to encourage social supports, especially during COVID, especially for families that are under-resourced or overstressed. Moms, babies, families are not, parents are not meant to care for their children alone in little isolated houses. We have moved from living as a community where moms and aunties and older siblings and people within our village are all together to raise a child, to really raising children in isolation, which is oftentimes when I talk about postpartum mood and anxiety disorders, I really cringe and I'm saying, is this a disorder that mom has, or do we have a disordered way as a community of raising our children? We know that parental stress has a direct impact on a parent's ability to attune to the child and to respond effectively. So connecting our families to social services, to WIC, to providing hands-on support, transportation, being in the home with them will impact the infant's mental health. Focusing on, so making a shift from perfect parenting and focusing on what is being done wrong, or needing to feel like we are solely responsible for the well-being of our child, to shifting to the importance of ruptures and repairs. This is from Ed Tronick's work, and he talks about how important it is for, in fact, in his studies, mothers were, quote unquote, correctly attuned and responsive to their infants about 30% of the time, and 70% of the time misattuned or not responding. And so why? The idea here is that it's important for infants to have the experience of, I gave a hunger cry, but mom didn't respond. She can't figure out what I'm saying. And I feel uncomfortable and I'm feeling misunderstood, but mom has the support to be able to stay with it, to try something different, to keep listening, to keep trying. Now I'm going to try to pat you on the back, and now I'm going to maybe change the diaper, and then maybe finally figuring out it's a hunger cry. And then the infant is soothed and they have the experience of, I can feel bad, somebody stayed with me, and then I can feel good again. That's what creates resiliency, the ability to tolerate distress in a supportive environment and know that I can feel good again. Looking at contingency, which is this back and forth communication between mom and baby, where the infant cues, we can help our parents to learn what are baby's engagement cues and disengagement cues, and how can we learn, for example, the child putting hand to ear, or the child, hunger pose, the child putting a hand out, that these are all cues of dysregulation that they need help, and how parents can respond. Even looking at the mirroring and the face-to-face interactions between moms and babies, and how moms can validate and support the infant's emotional experience through face-to-face interaction, with the Barnard Center and the NCAST assessment being tools that are particularly helpful here, as well as video intervention therapy or circle of security. Helping our families to increase their ability to mentalize, which is to become curious about the infant's experience, to see the infant as being separate from the parent, rather than putting our own unprocessed traumatic perceptions onto the infant. Oh, that means that they don't like me. That means I'm a bad mom. My infant is thinking this, that cry means that. That moms can stay regulated, become curious about the world through their infant or their child's eyes. And newborn behavioral observation and touch points through the Brazelton Institute being two great starting points for training in this area, as well as doulas. I really like to propose the idea of doulas as being so much more than birth support. It's not just about birth outcomes, but doulas being there to be the one who holds the mom and creates the capacity for mom to be able to connect to her baby. So doulas as mental health professionals, as part of that team, doulas as relational interventionists, very important in creating change. So conclusions. The experiences of moms during key developmental points during her own childhood, during pregnancy, during birth, and postpartum have an effect on future generations. Black, Indigenous, BIPOC, I'm sorry, my kids have just returned from school. BIPOC mothers are particularly vulnerable to maltreatment during these key time points. And the early relational health interventions, focusing on treating the mom and baby as a system, as a dyad, and not separating them out, offers the opportunity to create change in humankind within one generation. I love this quote by Bessel van der Kolk. The parent-child relationship is the most powerful mental health intervention known to mankind. And so these slides will be available. I have resources for more information here, as well as the references that were used if you would like to dig a bit deeper. And I am happy to take any questions either in the time that we have left. I apologize, I intended to go a little bit shorter. Happy to answer some questions here, or please feel free to reach out via email or phone if some thoughts occur to you later or questions come to mind. So With that, I will pass it back over to Irina if there are any questions.
Thank you, Carolyn, for such a fantastic presentation. I learned so much from your talk and hope our attendees have as well. I think this is the information we needed, especially after such a difficult year with trying to support parents the best way possible. So for our attendees, if you haven't done so already, please feel free to type in your questions. I do have some, and I will go ahead and dive in quickly, just to make sure that we keep within the time frame. So I have one here. You mentioned that our obstetric services oftentimes offer a high-tech, low-touch birthing experience. I think these words have never been truer during the pandemic, especially since many birthing people had to labor alone and were separated from their child as a way to keep everyone safe from COVID. How can we remediate the stress and trauma from this pandemic? How can we help moms that still feel traumatized by being so isolated?
Yeah, that's such a great question. It's such a great question. And so if I'm understanding the question correctly, you're asking what can we do now for moms who have had this very isolating birth experience? And then these moms are also going home, not being able to have visitors, not being able to have in-home support. What I would say is that there are many ways to feel connected. And so doulas are able to provide support in the hospital and postpartum via video. And so what we have done in our program is many times, if a doula was not able to be actually in the hospital on the phone or on an iPad or a tablet, the doula would just be there with the mom via video. And then same thing for postpartum. It might mean, you know, for 3 hours, I'm going to be here at my computer and you can pop in if you have a question. You know, I can hold a baby doll here and I can kind of show you the burping technique on screen. And I think a lot of times it's about not just having a 1-hour session where I'm going to come and go, but we kind of leave the portal open. Our doulas would normally be going for 3 or 4 hours. And so we can leave Zoom up for 3 or 4 hours. Mom, go about your day. And I am here. If you want to check in, if the baby is crying and you are having a hard time soothing, or we want to figure out together what that cry is or do swaddling, I am just going to be here for you. Doulas being that professional support, but family members or friends can do the same. Maybe think about not just calling to check in, but saying, you know, I'm going to be here for you. If you want to just pop in and call at any time, like I'm thinking about you and I'm here. Also, practical support. We may not be able to go into a client's home or a friend's home, but drop a casserole on the porch. You know, leave some treats for mom, a healthy fruit salad. Order in cleaning services for mom, or order in, you know, like a DoorDash or something else, just to try to alleviate that stress for mom.
I think those are great suggestions. Really, you know, oftentimes we ask moms, you know, call me if you need help, or, you know, reach out. But oftentimes, you know, when you're exhausted, when you feel so isolated and alone, it's hard for you to reach out to others and tell them specifically what is it that you need. And in general, what you mentioned are needs that moms need. They need to eat. They need to be supported when they're breastfeeding, or whether they're formula feeding. Moms have questions. So, you know, I think reaching out and providing tangible support is key. And just, you know, plugging in our services. The partnership has, you know, an emotional health phone support line where moms can call, and we can follow up with moms for an extended period of time. And there's also, you know, the great things of now with technology, the virtual support groups. You know, if you're stuck at home and you can't leave, or you feel uncomfortable, or you don't feel it's the right time, then you can log on and talk to other moms and talk to experienced facilitators. So I'll just continue with one more question since we're at 1 o'clock. Let's see, how can clients be in touch with doulas? Is this service available for mothers that are on Medicaid?
Yes. I'm so excited to share. For those who may not have heard just yet, doulas are newly able to accept Medicaid services. Also, many doulas will work on a sliding scale or will do pro bono work within their own practices. So we have both private practice doulas who may be accepting Medicaid or maybe doing pro bono. You can find them on Doula Match. You can find them on dona.org. You can find them on different birthing groups, either on Facebook or different social media outlets. Many doulas are able to provide low cost or free services. We also have in New Jersey, wonderfully, doula organizations that are providing community-based doula support. So this is a little bit of a different model where services are oriented toward under-resourced families. So where a private practice doula may be caring for the mom and the mom's family, a community-based doula, number one, reflects the community served. These are individuals who are from the communities that they are servicing. They may speak the same language. They may have grown up in the same sort of community. They're understanding the experiences of those families, and they're going beyond just supporting those immediate needs, but connecting families to community resources. So community doulas may be able to provide connections to WIC or transportation or links to social services, support groups for Black women in particular. So whether it's a community-based doula or a private doula who's able to accept Medicaid or pro bono, there are many ways for families. And I'm so excited that New Jersey is embracing this so that all families who want a doula or could benefit from a doula are able to have one.
Thank you, Carolyn, for sharing that important information. I hope that information gets transmitted more among families. So hopefully we'll hear more about that as that progresses. So that'll be our last question, just because we are on time at the time here. So to continue the conversation with our speaker, please feel free to contact her on the email that is listed. And to learn more about how the partnership supports mothers' emotional well-being, please visit the partnership's website at pmch.org. A quick reminder that in about an hour, you will receive an email with a link to a post-program evaluation. And again, your feedback is very important to us, so please take the time to complete it. And then you will be sent your certificate of completion, and that will be sent to you via email with the email that you provided. So just make sure that that is correct. And that should be received within a week or so. Before we end, I also want to thank our Director of Education, Sarah Mueller-Robbins, and Karen Amadeo at the partnership for helping make these programs possible, and of course the New Jersey Department of Health for their financial support. And just in case you are interested, a calendar of the partnership's upcoming virtual programs, including our past recordings, past programs, can be found again at the website, pmch.org, under the Professional Education tab, or also on our YouTube page. Thank you so much for spending a moment of your